Hey, my name is Chris. Thanks for tuning in. Today, I'm going to be talking about all the data that was in the CSOAP Trial Consortium paper out in 2016. This paper defended the fact that we should be giving azithromycin to patients who are going back for non-scheduled C-sections. Let's unpack the paper. So I'm going to break this paper down into four main sections. I'm going to go over the methods, then the design, the outcomes they were measuring, and then the results. So for the methods of this paper, they looked at roughly 2,000 women from 14 different centers, and they assessed whether or not they went for a non-elective cesarean section for the either indications of like failed induction of labor, non-reassuring fetal heart rate tracing, failure to progression, or abnormal presentation, or if they had rupture membranes greater than 4 hours, plus at least 4 centimeters of cervical dilation with 1 centimeter of documented change of cervical dilation, or greater than 50% effacement. The important exclusion criteria that they did was if they were already on antibiotics for choreo, if they had a scheduled C-section, then they no longer counted, and if the patient also had medications that prolong the QT due to the fact that azithro can do this as well. For patients who were GPS positive and on prophylaxis for that, were actually still included in the study. So for the design of the paper, so it was at 14 different sites, it was prospective randomized, and the pharmacist created bags that were either placebo or the actual antibiotic, and it was 500 milligrams of azithro in 250 milliliters of normal saline. And they would just pick the random numbered bag and then go and hang it, and then they would assess it afterwards, and only the pharmacists would know which bag numbers were which. But this was always administered pre-incision, which is different than other papers that were looking at post-incision or intra-incision administration. So for the outcomes of the paper, the primary outcome was a composite score of whether or not the patient had endometritis, a wound infection, or another infection within at least 6 weeks of their C-section. Endometritis was defined as at least 2 of the following, which was fever, abdominal pain, uterine tenderness, or purulent discharge. The secondary outcomes were focused on neonatal effects, so this was respiratory distress syndrome, neck, periventricular leukomalacia, grade 3 IVH, SIRS, BPD, like all the main ones. So jumping to the results section of the paper, we can look at table 3, and I can put table 3 up right now. The main thing we want to look at is the primary outcome, which was a composite score, and compared to the group with antibiotics and without antibiotics, 6.1% of the people in the antibiotic group got the primary outcome, and 12.1% got the primary outcome in the no antibiotic group. That means the relative risk was 0.51 when given antibiotics, which means they needed to treat 17 people to reduce 1 episode of a primary outcome. So either, endometritis, the wound infection, or other type of infection. Looking at endometritis, 3.8% of people in the antibiotic group got endometritis, whereas 6.1% in the no antibiotic group got endometritis. The relative risk for this was 0.68. Number needed to treat was 43. When looking at neonatal deaths, it was 14.3 and 13.6% in the antibiotic, no antibiotic group, respectively, which was not a significant difference. And when they controlled for smoking and diabetes, which would be obviously increased risk factors for having infections, the relative risks for all of those things, primary outcome and endometritis, were still the same. So looking at the secondary outcomes, which are focusing on the neonatal effects, this is table 4, which I got put up right now, which pretty much showed that there was no difference between the antibiotic and the placebo group. Another important thing to focus on as well was when comparing these two groups for at least the primary outcomes was looking at how the incisions were made. So this figure right here was showing that, if they use a different type of incision, so phalansteal or vertical midline, or whether they closed with staples, sutures, or dermabond, or how they skin prepped or the vaginal prep, all of those things were non-significantly different between the two groups, which means they likely did not contribute to the effects that were found with the antibiotics. So the last thing I want to talk about are the bacterial cultures. So the most common cultures were gram-negative bacilli, enterococcus, and staph. And there were significantly less bacterial positive cultures within the azithromycin group. It is unclear on the etiology as to how azithromycin reduced the number of infections. It is postulated that there was a reduction in mycoplasma or ureaplasma, but due to the fact that they are so uncommonly tested, it cannot be proven that that's the reason why. So overall, this is the CSOAP trial out of 2016 in the NEGIM paper, and I hope this helped elucidate as to why we give azithromycin to patients who have non-scheduled C-sections. Thanks for watching.